All right. Apologize for the delay. Had a couple follow-up questions from our last meeting. We'll go ahead and call today's meeting to order, October 30th, for our Hospital Authority Board meeting at 4:09. So welcome to everybody, guests and staff, for being here. I'd like to start out and provide an opportunity for anyone to disclose a conflict of interest that they may have. Seeing none, we'll move to the next item, which is the mission statement. Let's see who, yes, Dr. Nettles, would you be kind enough to read the mission statement?
All right, thank you. To improve the health and wellness of Nashville by providing equitable access to coordinated patient-centered care, supporting tomorrow's caregivers, and translating science into clinical practice.
Thank you, ma'am. Next up on the agenda is for public comment. Is there any public comment?
There are none.
Seeing none, we'll move to the minutes. If everyone's had a chance to review the minutes from our last meeting, do I hear a motion to approve? Is there a second?
Second.
Any further discussion? All in favor?
Aye.
Aye. Any opposed? Motion passes. Seeing no old business on the agenda, we'll move to new business, and that is ethics training. Derek Smith, who is our senior counsel from the Metropolitan Department of Law. Thank you, Derek.
Well, good afternoon, everyone. Just to help you understand this training session, we administer and or provide this training to many of, and all, I should say, periodically to Metro's boards and commissions. There are some things that are in Metro's Code of Laws that still pertain to this board, such as on ethics. But you also should recall sometime this year, you revisited and approved your own set of ethics an ethics policy and a form that you all complete, I believe, annually. And so modifying our general presentation to Metro to incorporate your differences as well. That's why we have provided you with a paper copy of these PowerPoint slides, and then with the assistance over here of controlling. I'll try to signal you if I'm saying go to the next slide, go to the next slide. So anyway, we'll commence. First, there's just a first slide with the goals of the training, and here they roll out. Primarily, we're going to talk at the initial stages of this training material about the acceptance of benefits, and that you can't do it if it's related to your official role. But there may be some exceptions of things you can accept when not connected to your official role, and some limits on that too. So we'll go over that. One thing you all had at the beginning of your meeting was a disclosure of conflicts of interest. That includes issues such as if you have bias or an actual transactional type of conflict of interest. So we'll be covering that topic generally as well. Third item, when you all have also the ability to disclose contacts or information you may have received outside of this meeting, that might be appropriate in certain cases too. We'll cover that topic. Number 4, you don't have to articulate reasons about why you vote to necessarily approve something or not approve something as your board, but sometimes you do act in a role or may be called to act in a role, such as when you sit as a civil service board. If that were to occur, you might have to express reasons for how you make determinations on those types of decisions. So we'll go over a little bit of that too. Number 5, that favorite topic, the Tennessee Open Meetings Act. We'll cover that. Let me just give you a preliminary understanding of why you're obligated to comply with the Tennessee Open Meetings Act, so you'll understand, how did we become subject to that? Just remember, there's a 2-part test under a Tennessee case. 1, you were created by a resolution adopted by the Metro Council, and the Metro Council is subject to the Open Meetings Act. So anything it creates is likely subject to the Tennessee Open Meetings Act if what they created has the ability to make recommendations or make decisions. You all have both of those. So that's what, by Tennessee law, obligates us to comply with the Tennessee Open Meetings Act when it comes to you conducting business or deliberating towards a decision. And we'll go over some of the requirements of the Act. Number 6, there'll be some general information. You guys do a good job on that, and the staff does an excellent job bringing you up to speed on how you can make informed decisions. And we'll just give you a few reminders in these slides about that. All right, next page. Getting into the nitty-gritty of not being able to accept benefits related to your official role. Metro Code Chapter 2.22, and it's a sub-provision of that, makes it explicitly an obligation on all Metro employees, and included what is the definition of a Metro employee? Well, it's not related to compensation. What it's related to is what by definition fits in that category. And it expressly states that all authorities of Metro, and you are a authority created by Metro. So that then means you have to, at a minimum, comply with the ethics ordinance. And then it has these bullet points that we've tried to summarize generally what to keep in mind about what you should or shouldn't do or accept and so forth. So the first one I think is pretty self-evident to you. You shouldn't accept or solicit a benefit that could reasonably influence you to act improperly in the discharge of your official duties. You know, this has things such as extreme cases of bribery, things like that. Or wink and a nod, yeah, I might go along with what is being proposed provided I, have a financial reward for doing so. That's prohibited, clearly. But anything that might reasonably tend to influence your decision is what you need to avoid. Use of Metro, just substitute sometimes where it says Metro, just think of it also hospital authority. So you shouldn't use hospital authority property, services, or funds for personal purposes. Using non-public information for your own personal gain. Let me just give you a quick example. If you knew that there's going to be a contract with a business that the hospital is going to approve, you don't want to be exercising your preliminary knowledge it's going to be coming before you to gain a stock interest that might be impacted by such a contract. Things like that. Next, please. Next one. You don't want to use your position improperly to either indicate you could grant privileges or that you're trying to secure unwarranted privileges. Not to you, but there's instances around Tennessee of people saying, because of my position, I should get to avoid having to pay the parking fee to pull up to this parking meter. Or you shouldn't be able to issue me a citation because I'm an official with the hospital authority. Things like that. Finally, you need to be careful if you're accepting outside engagements, even though you're not a compensated employee. Just keep in mind that some things you may sign on for could reflect on whether your judgment can remain independent on this body. I have to use some caution here and just indicate to you, you're not out there on an island trying to make these decisions. You can consult with us if you're involved with something or may become involved with something and you want an opinion. You can consult with us on that. But that's something else to just keep in mind. And then the last point, if you even reasonably believe that someone is trying to influence any action in your capacity as a member of this hospital authority, you need to consider that that's inappropriate and that you cannot accept it. Next, please. Those are the shall nots. Now, the hospital authority, practically each of you, some of you may not have been members at the time your policy was adopted, but it even goes a little further on some things. It says, very similar to Metro's, but it says you cannot solicit or accept anything of monetary value. And then it gives the list here: gifts, gratuities, services, favors, entertainment, lodging, transportation, or loans from any person who, and then it says how that might affect you. 1, they're seeking to obtain or contract or enter into a business or financial relationship with the authority. You need to refrain from those types of gifts, gratuities, etc. Any such entity or person who conducts operations or activities regulated by I'm not sure outside activities you regulate, but just thinking outside the box, to the extent you are in your civil service role, we're being impacted by outside influencers on employee policies, HR standards, things like that. You need to be guided in, steering away from that. Or anyone who may substantially is affected by the performance, if you have an interest, I should say, that would substantially affect your performance of duties. That's pretty broad. If you had any questions, bring them to us, because I can't spot these in a vacuum. Generally, the way a lawyer advises is we get the facts and circumstances and then we render the advice. These are just guiding principles, and they are designed to trigger thoughts of when and if you might need to either make a disclosure, and if you have any question about that, or if you need to recuse, or it's recommended you recuse yourself, consult. You can reach out, one, to the hospital's compliance officer, who will likely steer you to our legal department to give some sound legal advice on how you should respond. Next slide. Narrow exceptions. So just keep in mind, there are some narrow exceptions perhaps to those general, and if you want to know whether an exception applies, call on us. But this is, that first arrow, that's even more restrictive than the disclosure requirements that Metro uses under the Metro Code. But you all adopted that, and as you see, it requires disclosure of gifts from members or longstanding friends when it's to you as a gift, but it's not intended to affect your position, or it's a motivating factor, and the value of the gift is appropriate to the circumstances and consistent with your historical relationship. And think about even birthday gifts and things like that. It can't be under a guise to influence your decision here. You all adopted this asterisked matter too. Even if it is permissible, if it's a gift exceeding $100 in value, you're supposed to disclose it via letter to the internal auditor. And I attempted to reach out to Christy, and I'll put you on the spot, I apologize. But is this intended to mean the hospital's internal auditor, if you have that position, or is it meant to identify Metro's, because Metro has an Office of Internal Audit to which you guys can, or the hospital may be subject to as well. Here? Okay. So, again, and who is that person currently? It's not filled. Please send it to Christy standing in the gap. But if you have any such disclosure to make. But again, that's what you all adopted. So just understand that. I'm just delivering an outline of what you have agreed to operate under. It was in that policy that you adopted 4 or 5 months ago, I believe. Next, loans. Loans are not impermissible. You got to live your life. You may have a car loan, you may have a home loan, personal loan, business loans. But as long as they're made in the ordinary course of business and on usual customary terms, not something that could be viewed as trying to influence you or give you a benefit as a member of the Hospital Authority Board. The next one says you shouldn't accept or receive, well, you can receive, I should say, unsolicited advertising material of nominal value. This would be like, let's say someone wants to write an article of appreciation about you serving on the Hospital Authority Board. You didn't solicit it. You didn't ask for it. You weren't seeking to be, puffed up in the public eye. That's something that probably is acceptable. But it must be of nominal value. Probably shouldn't be something that you send out in your capacity, or have someone send out in your capacity as a board member, acknowledging your service and what all you do, and talk about your other accolades. They're going to give you that free to the tune of, some vast ad campaign. That probably should be, yes?
Just for some clarification, going back to the first paragraph, which doesn't suggest context, In other words, the way it reads to me right now, with the paragraph and the asterisk, that if my son-in-law gives me a bottle of wine for worth $250, I have to report it.
That's what that asterisk, if I were reading that based on the letter of what's expressed, it sounds like you're supposed to at least disclose it in a letter to the internal auditor. Again, if you want to revisit that and modify that, that's your options. But I'm just delivering what's in the current policy. So you're right.
I think we ought to
read that.
revisit that. Otherwise, I think many members of the board will be writing letters to the internal auditor from time to time.
I understand. I don't disagree with you, but I can only interpret, I mean, you've got an exception, but then there's a caveat to the exception. And, you know, that, yeah, as long as it's not a gift from a family or friend member that's trying to influence your decision on the board, it seems like the disclosure, you know, what's its purpose really? But there is that caveat right now. So again, that could involve some discussions and possible modification by board action. Sure. Next, please. Here's the one. Food and refreshments of nominal value if, and it says employees, by the way, these same restrictions apply to your hospital staff as well as you as board members. So, business lunch or dinner doesn't constitute such an event. But if you go outside of that and it's related to charitable, civic, political, or community events related to your official duties and position, food on site may be acceptable, but you need to be careful if you're being wined and dined. Just be on the alert that might at some point get called into question. And if you're at a business lunch or dinner, it says here you must, it says actually, buy your own meal and or refreshments at business lunches or dinner. And this is meant when it's not at one of these charitable, civic, political, or community events. Let's say you're having a luncheon with a hospital vendor. You should buy your own meal, okay? Perishable gifts like food baskets and things like that. You shouldn't receive those directly individually. It's acceptable to put those in a hospital or like at this meeting for everybody to share in. That would be permissible, but you shouldn't accept and retain things like that directly from someone that's saying, here, I appreciate your service on the Hospital Authority Board. You know, here's each month of the year, you can spend or get a meal at these restaurants. Well, you can't really share that with everyone else. But if they send in you one of, you know, some type of food baskets and things of that nature, just consider that you should place that in a common area for everyone to enjoy. If you got a gift or something and it's, oops, I forgot, or something like that, try to cure. If it doesn't meet an exception, you got to disclose it immediately. If it's an employee, they're supposed to do it to their immediate supervisor. I would recommend that if any of you found an issue that you began to question in an afterthought, report that to the hospital's compliance officer, and we'll work together to try to figure out how to rectify it, okay? Next, please. Now, this is something that can apply even though you're on the Hospital Authority Board, and that is the Metro Board of Ethical Conduct. It has been created, and it hears complaints and renders advisory opinions about standards of conduct, I should say, created by like an executive order that regulates ethical standards. What's important to note here is who has the authority to raise those complaints? It says any elected official, they're given the right to make a complaint with the Board of Ethical Conduct, or a member of a board or commission. And so since you're an authority board, that could be construed to give you all the right if you deemed an advisory opinion needed related to compliance, you could go to that step. Doesn't mean you'll necessarily get the advice, because there's steps to determine such with certainty that they believe your request fits within their jurisdiction. Next slide, please. If there was a complaint filed concerning an elected official or members of a board or commission, those are what gets sent. For example, if you suspected unethical conduct about an employee, they don't really hear those complaints. But if you were reporting what you perceived to be unethical conduct of an elected official or a board or commission member, file it with the Board of Ethical Conduct. Here's the procedural steps. What happens after that? The Department of Law investigates, evaluates, and makes a report to the Board of Ethical Conduct. And it gets into the analysis of whether it is believed to be within their jurisdiction, whether the facts, if proven true, would amount to an ethics violation, because everything that seems inappropriate may not constitute an ethical violation. And they're solely vested with ethical violations, not just best practices or things of that nature. Based on that report from the Department of Law, the Board of Ethical Conduct then decides whether to hold a hearing. There was a hearing here recently, as I recall, about an elected official within Metro. And so you may have seen and heard some of that and know the outcome. So these things do arise. If it's held, the parties are given an opportunity to present their case. The hearing is an open proceeding. Next slide. This is what can result from that hearing. The Board of Ethical Conduct could recommend to, this is Metro Council, that the person be censored. They could recommend that the person resign his or her position. They could refer the matter to the District Attorney General for prosecution, or the matter could be referred to the Director of Law requesting a civil action be initiated if it was a matter that somehow resulted in a financial loss to your hospital authority or something like that. It could be a civil action initiated for restitution or other relief. So there can be consequences. Main point of that slide. Next, our goal 2 now. We're kind of moving off of all that more technical ethics stuff and the Board of Ethical Conduct, and we're now moving towards the goal of trying to recognize bias or a conflict of interest in your decision-making authority for the hospital authority. One, you have a duty of independence. What does that mean? Well, you should not act on your own self-interest. After all, your duty is owed to the entity, the hospital authority. Second point, based on bias against or in favor of people you know personally. Just to illustrate, you may have a close business or personal relationship with one of the vendors that your hospital authority is going to do business with. If you're so close or connected to someone that you can't be unbiased, you probably need to consider whether you can or can't disregard that bias, and if not, consider recusing yourself from the discussion and voting on such a matter. Likewise, this could give rise, let's say you're sitting in your capacity as the Civil Service Board, and you're so connected to a hospital employee that you believe it would affect your independence in judgment. Probably best to disclose and consider recusing. Or if it exists and you want to make a disclosure and state, but I can be objective, impartial, I can disregard my relationship and, remain independent, hear the evidence and make the decision. So recusal isn't an automatic. But if you are concerned later on that someone's going to raise the issue, you weren't impartial because they know that every week you have a weekly luncheon with the individual that's an employee of the hospital, you might want to disclose that so it's out there in the air and open. And again, you've got a duty of independence not based on interest of a director or contractors with whom your board interacts. Kind of covered that as an example of what was the point here. Just fundamentally, you got to be impartial and act based on the law and evidence presented to you. That's more designed on Even here, when you make decisions, you get staff reports and recommendations. You should act on that guidance as opposed to outside evidence. Also, if you're sitting as a civil service board, reflecting on a disciplinary issue with a hospital employee and making a final determination, you got to act on the evidence presented to you. You can't make your decision based on how nice the person was to you in social engagements or outside things like that, of that nature. Conflicts of interest arise, and this can get in the weeds, so I'm just presenting bullet points. These are part of your guiding principle as you go through your disclosure forms and the policy and so forth. Conflicts of interest may arise whenever outside interests or activities of you as a member could interfere or compete with the hospital authority's interest. So, you know, you get your advance packets, you get the agenda. If you see something on there that you feel like, well, I may have a competing individual interest, you may need to disclose and recuse, or it may be acceptable to say, I can be independent and I'm not going to benefit financially one way or the other. If you're going to benefit financially, you really need to think long and hard about recusal. But just keep that in mind. You're also not to allow the interest of another board member, officer, employee of this institution, or even a volunteer to be involved in a transaction or arrangement that impairs your independence. Finally, an excess benefit transaction, I'd have to study exactly what that means. I'll be candid with you. Again, I'd have to start with a look at the facts you could present of what does excess mean? And then what is a benefit to you? What type of transaction might that be? And that could go back to some of those things that we talked about before. Maybe personal loans, property loans, real property loans, but you don't want to be, for example, if you were to be getting that loan from the banking institution for the hospital authority, you want to make sure that that's a total arm's length deal, not for the purpose of influencing you to the extent you got to make a decision as to who are the bankers, who are the lenders, if there is lending being considered to the hospital authority. You want to, keep that arm's length, make sure it's not intended to give you favorable interest rates, seeking to influence your decision to keep them as a vendor for the hospital. Next. Included in your policy, what has been adopted indicates disclosure is really the first step. So to the extent that board members or employees have any actual potential or perceived conflicts of interest, you need to disclose that on that conflict of interest disclosure form. And that takes place at stages. One, it's done upon hire. It probably even was done when you all were being considered for an appointment by Metro's council based on the recommendations of that flow to them for your approval. But that's on the Metro side where you're vetted. Once you come and become a member, there's the disclosure form that the hospital itself, that you all have said we now need to also disclose. Complete that form. Annually, all employees and board members are to update the hospital's disclosure form. And then getting to the immediacy is because it's not just, okay, when I first got on the board or when I gave my annual disclosure, I had no conflict of interest that I needed to disclose. But during the course of that year before I re-up, your circumstances may change. The advice is and recommendation, update. Okay? And then again, if the question is whether it actually presents a conflict of interest, this gets pretty close here, though, as to potential or perceived conflicts of interest. And we just have to deal with those on a case-by-case basis. Next, disclosing knowledge you may have received about an agenda item from outside the meeting. Now, that doesn't mean when you get your agenda and your working packet as board members. But let's say you had information gained because you happen to have had a luncheon. You know, a lot of you are physicians, professionals. There could be things in your work life that relate to, or, you know, one of the contracts that's being proposed may be a vendor that you have a decision-making authority outside of your role on this board. You may rely on a vendor either for IT services, that also is now being considered for IT services to the hospital. If you gain information about their operation or something outside of your role here and the reports of staff and recommendations of staff, it's recommended you disclose that knowledge. If you can still remain unbiased and impartial, you don't have to recuse. But if you can't set aside your outside relationship and knowledge you've gained, for example, just think, let's say in your outside of the hospital authority, you've seen the performance of a proposed vendor the hospital's considering, and you can't disregard the fact that you thought they were either excellent or you can't disregard the fact that they were terrible. You need to consider how that's going to impact your impartiality and unbiased decision-making here on this body. So these things can arise. But again, that's just a general explanation. Obviously, if you were approached in an effort to lobby you outside of the meeting, even if you didn't take the bait, you didn't go for the lobbying effort, it's best to disclose it, because we all now live in the age where there are cell phone recordings and cameras all the time, and they see you meeting with the president of or the CEO of one of the vendors of the hospital authority. Again, you can disclose that, and as long as it wasn't an effort, or if it was an effort to lobby you to approve their conduct or performance of a contract, it's best to disclose that and say, but I didn't act upon it. I didn't accept it. Knowledge can even include your expertise or experience. And by the way, this doesn't automatically exclude you. In fact, you are valued for your different efforts outside of the hospital authority in your professions, careers, your charities you work with, your services to communities. All of those experiences, you can't check them at the door and eliminate them entirely. But what you do need to consider is any of that such that when making a decision, it's going to be intolerable for you to exclude it from your information or knowledge. But, if you're a physician and you have some knowledge, that doesn't automatically mean that you got to check out of those proceedings. In fact, that would be almost make all our boards and commissions inoperable, especially this one, since that expertise is public relations experiences, ministry experiences. There's those components of work here within the hospital authority. Or can be. And so that doesn't mean just because you have a career that you can't serve on a board or commission. But again, just keep in mind, disclose any knowledge that you think affects something you see on the agenda. And if you want some advice on it beforehand, just reach out to us to get some thoughts. Next, please. Goal 4. This can get a little confusing, so let me give some parameters here. Whenever you all vote to approve a contract, or you vote to change, for example, your own ethics policy and things of that nature, you're not necessarily bound to articulate specific reasons. Those reasons are self-evident. If staff comes to you with a report recommending a contract, you're able to rely on that and make your votes. This is really guided more towards some boards and commissions that have some discretion to make decisions on things like someone came before the zoning commission seeking a variance or a board of zoning appeal based on a decision that they disagree with. Those types of decisions should be supported by that board or commission coming to a series of reasonings supporting their decision. If you're called to act as your civil service board, if you make a determination, you're likely to have to not only make the decision, but support it with the reasons for that decision, such as we believe the employee did commit the act, or we believe the employee did not commit the act, and therefore we don't agree or we do agree with the discipline that's been proposed. That would be one where you likely would have to give reasons for your determination. What are acceptable reasons? These are general ones, but they're acceptable. You believe your decision is supported by relevant guidelines or laws. You believe that your determination is correct because of the facts presented at the meeting. You believe it's supported by your, and here we go again, past experience. So you can have some past experience and rely on it as long as it's reasonable and supported to address similar issues. But that's generally related to, okay, we had a case just like this before us. Don't see any distinguishable facts, so based on our similar experience and issues that are being presented, we believe it's the same decision here. That's really what that is meant to apply. You also have the ability to rely on studies, opinions by experts, or sometimes even, and this one can get a little tricky, specific observations made by the public. That really shouldn't necessarily, I can't think of many circumstances where that would apply to your decision making. But think of it, as I said, in terms of public commenting about how much noise impacts their life from a business that's loud and rowdy. Things, you know, if you were a board or commission that had jurisdiction over something like that. But studies by experts, that could come before you at some time in relation to a matter in your capacity as a civil service board. Next. These are unacceptable reasons if you need to make justification for a decision. You know, acting in sympathy of an applicant. You know, we all fall into this, I really feel your pain, I empathize with you, but those types of statements really shouldn't be made because they could be used as a way to overturn your decisions, saying, wait a minute, you're expressing bias in your decision. So we recommend refraining from that. Opposition that's not based on the guidelines or laws, like this. It says the project may be noise. We already have too much traffic. But if that's supported by their experience of, we've seen the traffic studies, we know the traffic flow numbers, and they're voicing opposition, rely more on the expertise that said the numbers are too high if you're dealing with a traffic issue. But again, I can't think of many instances where you all are going to be hearing and making decisions that invoke these reasons that shouldn't be used. Next, please. Open Meetings Act. I gave a predicate for this as to why you all are subject to the Open Meetings Act. So here's what it means for compliance, and your staff does an excellent job of keeping you all in the guardrails on that. But first point of interest, you should absolutely avoid using emails between yourselves to discuss board issues or to invite comments from other members concerning what you would be doing otherwise in an open public meeting. You can have emails with staff getting information and so forth, but don't try to use that as a guise, is my suggestion, to say, well, what are the other members thinking about how they're going to vote on this, or what are their questions about this issue? Staff is going to push back on allowing that to be done. And as you all now know, as just about anyone that does business with a governmental entity, it doesn't matter whether the email is from Metro or the hospital authority email address or your own private email address. If it concerns hospital business, it's really going to be viewed as, does it meet the test and standards of Open Meeting Acts? And it can be producible under the Tennessee Public Records Act based on a proper request or a subpoena. Because if it's about the board, it's deemed a public record, okay? Violations of the Open Meetings Act. Whatever you decided, those deliberations and decisions are void. They may be subject to a way of curing later, but just think about that gap. The action you took, it may not be, it was void at the time it was made. And we may be down quite a ways down the river already, acting on that decision that could be deemed void. Another thing that can and has happened to other metro bodies, a judge can order and place you under court supervision. So those are the stings to violations of the Open Meetings Act. Now, there are some exceptions. Go to the next slide, please. Well, first, let's talk about what is a meeting. Meetings with 2 or more members are deliberating towards a decision or making a decision. And again, that can happen in verbal communications outside of a board meeting. It could happen in email exchanges and so forth. So just be aware that it's when 2 or more of you are connecting in some way to make or deliberate towards a decision. What are the requirements to have an open meeting? The public notice must be given for all meetings. The notice informs people in the community of what business is going to be conducted and lets them to prepare. Finally, what is adequate notice? There's not a real specified time frame. Metro prefers 5 days in advance of the meeting. State law says you can't at all consider it as a legislative body, which you aren't, if it has to be published at least 2 days before a legislative body acts. Otherwise, we've got these court decisions where the courts would actually determine if adequate, sufficient notice is given under the circumstances. But it has to be designed to fairly inform the public of the meeting and the purposes or what business you're going to conduct. So that's why you have an agenda. That's why you get a list of contracts. If a contract's going to be considered by you, the public is aware of the business you're conducting. And that's also why staff attempts to get those agendas and advance packets out a week in advance of your meeting. Next. These aren't considered meetings. In fact, there's specific exceptions. On-site inspections. If you all were to seek to tour another medical facility or something like that, provided during the site visit you can't deliberate or make a decision. But you can make the site visit as a board and not have to publish notice, although you could publish notice, but it's not mandatory. Kind of consistent with on-site inspections, there's sometimes our trainings, like this training that I'm giving you tonight. The choice was made to present it in a public open meeting, which you can do that, but we could have convened for the purpose of having a training just where I present, someone presents the topic to you, but you all don't deliberate or make a decision. Next, a chance meeting or an informal assemblage. You know, that's obviously where you're not meeting to try and deliberate or to make a decision, but you're not expected to ignore each other's presence. If you happened to walk into, let's say you went and there are other members at the same function. You didn't know it. You didn't plan it that way. That's also why we recommend, and you all are good at it, giving you the opportunity to disclose you had a chance encounter, but we didn't discuss board business and then you can fill in what the meeting was or what the function was and things of that nature. As you all are also well aware of, and the law permits you to get legal advice, executive sessions, and those are with attorneys regarding anticipated or ongoing litigation. But understand this, during those meetings, the lawyer expresses and gives legal advice, pros and cons. You all may ask the attorney question, but you can't deliberate or decide an issue affecting the litigation until you come out of that session. And in an open meeting, you'd have to, if it required a decision, usually it happens, let's say there's a dispute and you get the legal advice in the executive session, and then you come out here and you discuss and you vote whether to approve a settlement or a release agreement regarding the subject matter of the litigation. Now, you all also are aware under Tennessee law, hospital authorities are given an exception further than these for being able to go into closed session, not executive session, but closed session, for the purposes of developing strategic plan or marketing strategies. But again, during that session, you discuss it and all, but you can't make an actual decision. To make the decision on what is your strategic plan, you have to come out of the closed session, and when it's ready and viable for presentation and a vote, you have to openly discuss motion, second, discussion, and then the vote to approve or not the strategic plan. Same goes for marketing strategies. If you're going to develop one, you can discuss it in the closed session, but when it's finally to be adopted, it's got to be presented in the open meeting. There's one limitation on that, though. If you are in closed session and you receive any documentation about strategic plans or marketing strategy, those have to then be made public for 10 days before you can vote on the matter. So it's a cumbersome rule, but that's what the state legislature, to give you some leeway, but you have to then comply with the other components of the law. Next, best practices for making informed decisions. And that's why this hospital staff is so good. They give you all the information so you can make informed decisions. And what do you need to do with it? We suggest you got a detailed agenda. Not only does it inform the public, it informs you. And then what does that say? Second bullet point underneath. Well, there's two sub-bullet points there. That you can review relevant documents or contracts to prepare for the meeting. So that's a part of due diligence and is reasonable steps you could take. And you have asked staff to do that, and they're doing that so you can be informed. Provide a staff report. That's whenever they're bringing something to you. They provide reports. The information you've asked them for, they include it on the agenda or in the materials in your package. Staff is implemented consistent with legal advice too, what we've kind of covered here and what you all did earlier at the beginning of this meeting, declaring conflicts of interest or recusals on agenda items if you needed to make such a disclosure at the beginning of the meeting. Next, getting back to you all, and it kind of dovetails and overlaps with what staff should do for you and what you should do with what staff provides. To get a framework, though, and understanding, it's important for you to understand the work of the hospital authority, and I think most of you have become well acquainted with that or in that process. Meeting with leadership, asking for tours, reviewing your key documents, reviewing key contracts. Not just the ones that come before you for a decision, but you may have questions. You always ask staff, hey, I'm curious about what do we do for this service? And that may have been a contract in place for a few years. You're entitled to that information. If you need a legal or historical context for past decisions, you can seek that from staff also. Individually, if you're seeking it in the public meeting as a group, then it would have to be disclosed and done during a public meeting. But you individually can get acquainted with the hospital. Dovetailing back to staff needs to prepare, and you all should review before each meeting the agenda and the relevant documents and any staff reports. Finally, something that you could consider, and I think you all may do some of these, consider the metrics that could be used to help you all track. Are we acting consistent with the timelines, whether it comes to the performance review of a CEO, considerations of proposed compensation for the CEO? Are you acting timely and in accordance with your duties? Other things that you all do is consider, are we having reasonably and seasonably conducting our meetings by your committees and so forth? You want to keep up with that, see if you're doing it. If you got a committee that hadn't met in 2 years, you might want to consider, do we need that committee? And if it's one that's mandatory under your bylaws or something, I would recommend and suggest you meet more than every 2 years. Anyway, that's the end of that topical presentation. Can you go back to that? As you said, yeah. It's got my email address and my teammate Matthew Garth's email address too, if any of you need to ever connect with us, feel free to send us an email, okay? Any other direct questions right now about this general topical training? And by the way, we do this about every 2 years, but when a new member on boards, some of you have heard some of these topics. I've discussed them many a time, but others of you that are newer members, this is designed to help you, to become informed about your roles and duties. And then finally, as new members roll on board, we'll try to figure out a way that they can have a conversation and get a copy of this. Okay? Thank you. Yes.
Derek, just to be clear, if a group of us got together to go visit another hospital to see, how they're doing things, as long as we didn't deliberate, we do not have to report a public meeting.
That's correct.
Thank you.
Let me just mention one. Best practice might be to disclose you had the site visit, but it doesn't require that an agenda and the public is invited to the site visit. That's not mandatory. But I think you all are pretty open in your disclosures of when you're going to go somewhere, whether it's a community carnival or a community-sponsored event, but you'd like for all of you to go. You express that. Those could be site visits too, as long as you're not deliberating, to your point, towards a decision of this body. But yeah, that's part of gathering information. Okay? Anything else? Thank you.
Thank you, Derek. Appreciate it and your guidance on these topics. We've come a long way, both with where we've been in, I feel like, board compliance, and I'm really glad to see that Derek's been a really strong partner for us. I know he has been for me in terms of being able to bounce ideas off of him. So when he says he's, open for you to call or email him, he really is. So to make sure you use him as a resource. Pharmacy. We have a specialty pharmacy report by Dr. Brown and Dr. Jeff Hardwick.
How's it going, guys? Thank you for the opportunity to present today and catch everybody up on our specialty pharmacy venture, which is happening over at Nashville Healthcare Pharmacy at our Metro Center Clinic. I'm Jeff Hardwick, the pharmacy manager. I'm going to kind of rush through this a little bit. And first question is on the next slide. What is specialty pharmacy? That can be, it's not just because I'm there, even though Ms. Sharon says that. It's specialty medications are pretty much any medication you see on TV, these commercials. It's usually a very niche, small population medication. You can think about our specialty clinics where it's oncology, cancer drugs, rheumatology, hepatology, treating HIV, GI, these very immune disorders. So small populations still takes a lot of research and development. So these drugs can be very expensive. Some of our drugs can cost $30,000 a month. So as you can imagine, insurance companies aren't really happy or quick to throw out this cash and cover these medications for patients. That's where we come in. We've got a dedicated team to help get these approved, help the providers and patients navigate the insurance process. These medications also require very close monitoring and adherence monitoring, side effect management. So we have to go through accreditation processes to even have access to distribute these drugs or get them from the manufacturer. So why do we need this? The patients. Up until now, patients were forced to go outside of our system to other specialty pharmacies to get these medications. After they leave here, I can't guarantee what kind of service they're going to be getting or, frankly, if they'll even get that service at all. So they're kind of, after they leave our umbrella, they're on their own, and we don't want that for our patients. So we want to guarantee that they're going to get quality, timely service. So thank you for the board for approving this project almost a year ago, so we can help serve these patients. This also helps the providers and staff. I want the providers and secondary staff to be the best at being providers and secondary staff, not insurance experts or formulary experts. So we're taking that off their plate, letting them go back to doing what they do best. lastly, pharmacy, it'd be great if we could generate some revenue out of this, obviously, and then we can use those dollars to help accomplish our mission, and that's providing equitable access to care, extending our reach into the community and the underserved populations. All right, so how is it going? So we started off right at the tail end of February. This is our script volume here, and you can see we had some pretty sharp increase. The adoption rate by the providers was really well. Around July, we picked up beginning of July, we picked up a new pharmacy liaison position. Lane Hamby's back there. He really helped work with providers and patients to get patients into our system. And I know the script volume looks low, but these numbers on this chart represent $2.7 million of revenue. 55% of medication spending in the U.S. in the year 2022 is specialty medications. So this is a huge dollar amount representation here by these scripts. Our average script cost was $8,500. All right, so things were taking off, and you think that's good, and it really was. But we look at our drug spend, and as I mentioned, these drugs cost a lot. So as we're progressing on, it was costing us quite a bit of money. So every month, I'd call Mark Brown, Dr. Brown, and I'd say, we just had our best month yet. And I just dug us into a hole a little bit bigger because the pricing model that we used, and we partnered with a company called CarePath, which has been very great. Their pricing model, or that model works with 340B. And you guys went through the presentation with Bowman last month. And when we became a 340B covered entity, that was in February. Well, it takes several months for that to become active. So February up through July, we were a covered entity. We were buying medications. We were gaining the accumulations, which is the discounted pricing, kind of storing these away, but we weren't able to cash them in. So we had a pocket full of coupons, but we couldn't take them to the store. Well, August came around, and we went live. So you can see the inflection point where we were able to start using those 340Bs. Our retail, our WAC cost spending was going down, dropped about 200 grand to August, 200 more grand to September, October, where we are now. These numbers are up to date from yesterday, down to 100 grand. So I know the finance people were ringing me off the hook in July, wanting to know what was going on. And I hated to tell them, like, we're doing great, but we just, you just got to bear with me because we're going to get there. All right. So we can go on to the next one here. And this just kind of mirrors that last slide. The savings, this is 340B savings, what we would have otherwise spent. So in August, when it was coming down, we saved 350 grand. September, October, we just spent 100 grand. It would have been 330 grand if we were paying the full price. So, we are there, and things are moving in the right direction.
Can I ask a question? So in October, we spent 104,000.
Retail and for the WAC cost, yes, sir. And then we also spent another 100 grand in 340B. So total, we spent $211,000. Yes, sir.
And do we know what reimbursement was for those drugs?
Yes, we do. And I will get on this next slide to the margin there, and I can actually provide those numbers to you more in detail to the board. And I will say this, as we were spending all that money, like this, let's say the most expensive month, 678 grand, we were reimbursed all that money. So we got all that money back. So we didn't have a negative reimbursement. However, the partnership that we chose with CarePath, our specialty pharmacy partners, it's a revenue splitting model. So of the total revenue, we give them 22%. So we were spending 700 grand, making 700 grand and then some, and then we'd have to give them 22%. So it was digging us into a hole. And you can see that on this slide here. As we got busier and busier, we're making less money. Now, in August, when we're able to use our coupons, we can go shopping. You can see in September, we went from August losing 66 grand, basically the commission we were paying to our partners, to making 66 grand. For October, through the 29th of October, we've doubled that again, making 125 grand. Last week, we just cleared a roadblock that we had been facing for about 3 months with the PBM Optum, which facilitates TennCare claims. We weren't able to process any 340B claims for TennCare for the past 3 months. We were finally able to get that resolved just last week. So we're going to see even less WAC spending and even more profit margin, because as that revenue, our volume can stay the same and our revenue will decrease because the dollar amount of the drugs we're selling is going down, if that makes sense. So our commission will also go down. So that margin is going to push out further. So if we just repeat, and then we also are making a few bucks from our normal prescriptions at the pharmacy. So in October, that was about 25 grand. So that put us at 150 grand. So if we can just repeat those numbers for this next fiscal year, that puts us at $1.8 million of profit margin. We don't have a lot of personnel cost. One pharmacy manager, one part-time pharmacist, and one full-time technician. Our pharmacist liaison is covered by CarePath. We recoup that money from CarePath. So I think we are finally where we need to be. I think it's going to be very profitable. I'm putting our sights at $2 million, or if not 2.5 for the next fiscal year of profit margin.
Do we encourage patients on discharge to fill prescriptions here?
So we do. While we cannot, force them, obviously, we definitely tell them what we have to offer. We have free delivery. Most of our PAs, the prior authorizations that can take weeks when patients leave our system, we are accomplishing in 48 hours most of the time, if not less. If there's a roadblock with that, we work with the provider to get a formulary change real quick. There's many benefits, and the uptake has been very good, and the providers as well. I wasn't sure how well they were going to adopt it, but once they saw that, we don't have to fool with fighting with the insurance or spend an hour filling out forms, they've really jumped on board. So it's been pretty quick uptake. My pharmacist liaison, again, he's going to each clinic day and he's talking with patients and really boots on the ground.
And Dr. Miller, I do want to mention our pharmacy has a meds to beds program where they also deliver meds to the bedside for those discharged patients. And so as you see, Jeff is pretty passionate about what he does. You can tell through his presentation. And so I just wanted to say that. Thank you to Jeff tonight.
Thank you. And Camille Dow runs that meds to bed program, and she is really doing a great job.
That's a really good program, especially for patients that have some type of coverage. So
For sure. And so where can we go from here? We talked about reducing spend. The second thing here is big, reducing leakage. So this goes to what you were asking about, the adoption rate of patients. So although we've done really well, 65% of the scripts, we're monitoring the EMR, the database, the prescribing database. 65% of those specialty prescriptions are still leaving our system. So we're working to make that number down, keep those patients in-house, and better outcomes for them, and also bolster our business. Changing the payer mix will be is going to be huge. We're always going to take care of our Medicaid, our TennCare patients. We're always going to take care of the uninsured patients through patient assistance programs. We're always going to hawk down copay assistance for if someone's copay is thousands of dollars. We get it down to zero, if not close to zero. So we're always going to do that. We're always still committed to equitable access to care. That's in our mission. So we'll leave no one behind. However, the more private insured patients we can capture, bringing them into the hospital, into our specialty clinics, that's really going to extend our margin and give us those dollars that help us reach out to the community. An example of that would be, the Metro employees and the state employees now. Many of them probably don't know what we have to offer, and the specialty clinics for sure. So getting the word out there would be very good. So, and the last thing is something that we're working on. We were able to retain 81% of the prescriptions that came into us. The ones that we had to transfer out were either because insurance wouldn't play nice with our pharmacy, like they just wouldn't allow them like contract with us, or the medications themselves we may not have access to. We're just starting our second accreditation, which will help open up payers and also open up access to these limited distribution meds. So we're working on that end too. So that's all I have, but I'm here to field any more questions if you might have.
In case it's not obvious, Jeff has driven this thing single-handedly pretty much. And we got together several months ago, and he told me about, the plans and the dream that he had, and you accomplished a tremendous amount.
Well, I appreciate it.
Congratulations.
Thank you, sir. Former director Evelyn was instrumental, but the hospital, so many teams, IT, instrumental, finance, contracting, everybody. It was a huge team effort. And shout out to my pharmacist, Delegi Ayad, and Morgan Smith, and Lane Hamby. That's been my solid team, and they've had my back, and it's really starting to show.
So we didn't have a 340B program until February?
Well, so this new pharmacy, we just had our 1-year anniversary, right? And that pharmacy was going to be filling 99.9% of the prescriptions were going to be from the clinic over there. And that clinic is not, as of now, a covered entity clinic. So none of the prescriptions will qualify. So we didn't even qualify or make the pharmacy eligible. After we started talking about this, the specialty pharmacy, we said, oh wait, we do have to do that. So it would have been great if we had those ducks in a row before we got into this, so we could have hit the ground running. But I don't want you guys to look at that slide that had the profit margin and see those negative numbers and think we just lost out there. Every prescription that was filled in there that qualified, we were stacking away a coupon. So we've got a large cash, and now over the next few months, several months, we're going to be redeeming them. So we will get some of that money back, or a good bit of it.
Are we advertising to Metro employees and other private pay that we have these services?
So it's something that we should improve more. I know that financial limitations have kind of handicapped us a little bit from the beginning of marketing outside, but I do know Kathy Poole and them have done a decent job. I don't know what exact efforts of spreading the word to. I know that actually we went to the Waterworks one day, we went to the NES one day, so we are trying to spread the word. I'm not exactly sure what projects are undergoing, but that is good. It is important, though, to mention that private payers are good, but they need to be seeing our doctors at the hospital, right? So putting up a billboard that says Jeff's Specialty Pharmacy, that's not going to be great, because when we sell those prescriptions, although it's great to help those patients, we are not able to qualify those prescriptions for 340B. So we pay full price, and then we pay 22% off of that to our partners. So getting them into our system is really ideal. And then we got them start to finish, and then we can ensure the patient care all the way around. So it's a little convoluted, but yeah, I think we're in a good spot now, and we can hit cruise control. And yeah, thank you guys. I appreciate the vote of confidence.
All right, thank you. Next up is our medical staff report. So Dr. Bullock.
Good afternoon. I'll be giving the update on the bylaws. I am happy to present that after all of our work starting in February, the medical staff bylaws are finally out with the medical staff for vote. Started October 23rd. We will close voting on November the 3rd. As of this morning at 10, we were only 7 votes from quorum. So hopefully at the next meeting in November, we will be able to bring those to the board for ratification. I will take any questions.
Thank you. And next up is our October credentials report, Dr. Miller.
So the medical staff met last week and approved 8 people for initial appointments. Christian Failer, a nurse anesthetist, Mary Hurley, family nurse practitioner, Timothy Brachetto, Scott Bergie, Donald Hollis, Marshall McGow, Elena Mendoza, and Jennifer Stewart. The reappointment were Bolani, I'm going to mess this up, Azian Volta, Rosalind Hatchett Pope, Marina Adele Gayed, Julie Elizabeth Davis, Cherish Elaine Fanakos. All of these have been reviewed by Dr. Bullock or their chiefs of service.
All right. Thank you very much. We will need a motion to approve the October credentials report. Do I
Move
have-
approval.
Is there a second? Any further discussion? All in favor?
Aye.
Aye. Any opposed? Motion passes. Thank you, Dr. Miller. Next up is our CEO Performance Search Committee report. Dr. Escobar is out today. So we do have another committee member that would be willing to give an update? Oh, okay, I'm sorry. My bad. So that will be deferred until next month.
Do you know where things stand? I mean, it seems like this is dragging out.
Yeah, it's in Metro's hands, I believe, at this point. I mean, I know that David speaks regularly to Metro, so I'll ask him if it's possible to get with the right wording and appropriate dissemination, following the rules that we've just learned about, maybe an update to our board members. So, Janet, do you mind working with David to disseminate appropriate information? Thank you.
Madam Chair,
Yes, ma'am.
apparently on the credentials report, we missed a page, the last page under the temporary privileges and the resignations.
Okay.
Thank you.
Temporary privileges, so there's pending board approval, temporary privileges, Mary Hurley, Elena Mendoza, Donald Hollis. I thought Scott Bergie, I thought that was already. I guess not. Okay, Christina Failer, Wong Lee, Christian Karamia, and Philip Brooks. All of these would be temporary privileges. And then we have 2 resignations, Colton Brown, CRNA and Anesthesia, and Elizabeth Carpenter, Radiology.
So, yeah, I was going to say, seeing that we missed this piece, would the appropriate piece be to amend our previous vote, Derek, or should we take a second vote on the temporary privileges and resignations?
I would recommend a motion to supplement the report and to adopt and accept that supplement.
Okay. Do I hear a motion to?
So moved.
Yes. Is there a second? Any further discussion? Oh, yes. Excuse me. Who hit the second? Yes. Sorry. Dr. Scott, thank you. Any further discussion? All in favor? Aye. Any opposed? Motion passes. Thank you. All right. Next up is our Compliance Committee report. Dr. Martin and Ms. Chrissy Lewis. Thank you.
I'm going to call on Christy to do the report, but let me start by saying we had a few meetings. It is very impressive what Ms. Lewis and lots of other staff did to put together things to assure me and now assure you that we are in compliance in many areas. In the areas we're not, we're working on it. So we met for quite a long time, and I've asked for a summary and invite questions for any details.
Thank you. I am Christy Lewis. I'm your Chief Compliance Officer. I will give you a summary of the Compliance Committee report. We first started with, as you know, compliance partners with many, if not all, of the departments. And the ones that we have highlighted here are first starting with IT and IS. They outlined the security framework and the safeguards for the hospital. And the topics included access control, vulnerability management, cybersecurity awareness and training, HIPAA and system controls, and user audits. We then moved to auditing and monitoring. We did hear from Revenue Cycle Services. In Revenue Cycle Services, we were pleased to learn that in the billing and coding that we exceeded the benchmark of 95% or greater. That was 96% for the inpatient, 97% for the outpatient billing and coding, and 94.8% for the DRG coding. If there was any corrective actions that were required, that followed up with additional training and re-auditing for submitting to adhere with compliance with the corrective action and the training reinforcement. We then also outlined our vendor and provider exclusions. As you are aware, under the Social Security Act, it is imperative that the hospital conduct on a monthly basis, vendor exclusions and provider exclusions to ensure that we are not partnering or employing any vendor or physician that is on the exclusions list. We're very pleased to inform everyone that we submitted all of our vendors. None of them were on the exclusion list. We submitted 218 providers. That's including nurse practitioners, physicians, all of our healthcare providers on that. Initially, we had 210. Of those 210 were identified as not being on the exclusion list. There were 8 that were required additional information, and they too were also cleared. So none of them are on the provider's list as well. We did move to our conflicts of interest, and I'd like to inform the board you all had 100% compliance with conflict of interest in the disclosure form. At the time of this reporting, we had 83% completion on that, with the remaining 17% of the leadership population for the Hospital Authority Board that will have until November 7th to complete the remaining disclosures we have. That 17% is comprised of individuals that may have been on FMLA, that may have been on some type of leave. We have resolved those, and we have given the remaining people who have not finished those until November 7th. And we will have future incentives as we continue this on an annual basis to ensure that there is 100% completion on a much earlier basis. So that will be addressed on that. And turning to our 340B compliance and what we have, that we did partner with, and the board did approve, and we have partnered with a company that is ensuring our compliance with the 340B program. The most important things I'd like to highlight are dealing with the savings that we have. Right now, we have recouped about $500,000 in savings in using this program, and we are on target to recoup $800,000 in savings. Also, that we are expanding the program to capture prescriptions that are filled outside of the hospital with pharmacies that will increase our 340B revenue. We had an employee that spoke to that earlier, so we are partnering to increase that as well. We then moved to talk with our HR department, and the highlight of that is that we do have an exit interview process that does include our providers in that process. And this quarter, we did have 4 providers, so that we had a 100% completion rate to have that process. And the process is geared to be a face-to-face process that includes that for physicians. There is a 2.2-part purpose of that, and that is to recoup employees when it is possible, and it is also to provide clarification or understanding for things that we may need to be aware of in the exit as they are exiting. And so we were pleased to say in this reporting period there were 100% completion rate with that, with the 4 physicians and having that completed. We are going to continue. We are partnering with a vendor in the future so that it will be a more streamlined process and it will be more automated and it will have less paperwork. So there will be less reliability on human connection, so to speak, and it will be more automated and a greater transparent reportability on that. On to the compliance reporting. We did have many things that we have been doing in the compliance department. Number one, that we had the annual completion of the annual risk assessment. This is something that the Health and Human Services Officer Inspector General requires of that, and we have completed that, and we are currently working on that assessment. On the risk assessment. It has been prioritized and weighted, so we do have that for the hospital, and so we have completed that as well. And the process of getting information for the risk assessment, not only is it through our surveys, but it is also through our hotline reports, our incident reports. It is also through phone calls and one-on-one conversations. So there are 3 modes of entry of getting information. It's also a reminder that the risk report is a living document. So it is something that is updated on a monthly basis and recalibrated and prioritized according to what has been reported. Also, we have in our hotline incident reporting, we do want to enforce. We have had our campaign on that, so we want to make sure that if you see something, you have the right to say something, and you have the right to say it without fear of retaliation. During this reporting period, we had 3 that were submitted to our hotline. 2 have been substantiated and remediated. The benchmark for remediation is 30 days. We completed the first one in 12 days. We completed the second one in 15 days. And as of this time period, we do have 1 that remains open, but is very close to resolution. And we are working diligently with our HR department on that. For quality, we wanted to report in this reporting period, we did have Department of Hearing surveys. There were 8 that were reported in this reporting period. 7 of them were closed with no findings. There was 1 that did have a conditional finding, and that one is being reopened by the Department of Health for investigation. So we anticipate having the Department of Health to come back out for additional work on that investigation. In terms of additional compliance reporting, we do have our annual compliance work plan, and we are working towards that. At this time, we have about 44% of that compliance work plan that is completed. We had over 50 entries, I believe, that we have on that. So to have 44% is a pretty good. We intend to have additional things to report on in terms of completing what has been completed, and we will report out against that compliance work plan at every reporting quarter. For our open litigation cases, we do have 1 breach of contract, 1 medical malpractice, 1 slip and fall, 1 personal injury, 1 investigation, and 1 EEOC case. This concludes the summary of the Compliance Committee. Thank you for your time and attention.
Thank you very much. Very comprehensive. This is a committee, for those of you who are new, that has not met in a while. And thank you to Dr. Martin, who, has worked in partnership with Ms. Lewis and getting this back on track and having such a deep dive on this. And again, it's great to know the work's being done. But at a board level, I think it's helpful for us to have confidence in that and has some visibility. So thank you, Dr. Martin and Ms. Lewis. Next up is our Advancement Committee report, Craig Lesser.
Thanks, Madam Chair. This was the very first meeting of the Advancement Committee, and we spent much of our time, as you'll see in the notes from the meeting in your packet, that we spent a bunch of time just talking about who we are and what we're doing. Very basically, with presentations from the Senior Director of Marketing, from Kathy Poole, from Alicia Fair, the Senior Director of Population Health and Clinical Research, and of course from the Foundation, from Kate Haygood. We did discuss our goals, building community trust, guide fundraising and donor engagement strategies, support marketing, branding, and advocacy, deepen partnerships with civic and government leaders, identify new board members for hospital authority and foundation, and serve as a bridge between hospital leadership, the foundation, and the broader Nashville community. All of that in the context of the broader discussion about what happens next, what's the future of the hospital, its location and consideration. I would ask if Ms. Poole has anything to add in terms of any specific update for marketing for this meeting.
Good afternoon, everyone. At your table, we did pass out a calendar of events as well as information on the All-Weather Wellness Fund. It's about to get pretty cold here, so the foundation accepts new clothing through the QR code for their All-Weather Wellness Fund. But then the NGH Emergency Department has created a kindness closet. And what's special about this is they do accept gently used clothing. So this is going to be more an internal request because before we just don't want everybody bringing in used clothing. So yeah, no business attire. We need things for the patients. So there's a list there. On the calendar of events, just some things to point out on the back. We will be having a lung cancer resource fair here on site November 7th. We'll actually have a huge set of lungs outside on the back patio. And then in collaboration with Meharry for Prematurity Awareness Month, I don't know how many of you know about the Busby Garden. As soon as you walk in, there's like a little atrium area. There's actually a fountain in there, which they call the pond, and we're going to start putting baby ducks in there, representing the children, the babies that are born here. So starting November through next November, we'll be adding the ducks. But this is just our kickoff celebration for that. I do want to address what Dr. Hardwick was bringing up about the Metro Incentive Program. We work very closely with Metro HR. When Metro benefits are sent out to all 20,000 lives within Metro, we do have information included in the packets about the Metro Healthcare Incentive Program. We also do an annual review with all the Metro HR directors, so it's presented there. And then we also work directly with the Metro PIOs every month. So information is passed directly within the Metro departments. Today we were at Metro Water. They had about 300 employees, or I think they said 900. I think it was probably closer to 300. That came through. We did wellness screenings as well as our ambulatory team set up a pop-up flu event there at site. We have another team member tonight at Maplewood. So we really push for the Metro schools and then our Metro departments because we know that is the low-hanging fruit to get people in the door.
Any questions for Kathy? Kathy, thank you.
Thanks.
I want to add 3 items associated with the foundation. First, we have elected a new chair of the foundation, Ellen Jansen, and she'll be working with each of the members of the foundation board to discuss issues that we want to move forward with. And I've asked Ellen if she would begin to have a series of meetings with Veronica Elders, our interim CEO, so that we can continue the path of having the foundation and the board and hospital working in concert, working together to make sure that our goals are aligned, the money can be raised for specific items of priority for the hospital and for its patients. Second item, I would just like to encourage our board members here at the Hospital Authority Board, if you haven't made a contribution, please do. Again, we've discussed minimum contribution, if that's all you can do, is most graciously accepted. We have 6 board members that have made the contribution since the start of the fiscal year, and I personally would like to see the rest of the board complete its contribution before the end of December. That way our foundation can move forward in requesting money and saying to foundations, other foundations, business, and other individuals that our full Nashville Hospital Authority Board is on board and supports the foundation. And third, I would like to announce that Kate Haygood, who has been doing such a phenomenal job with the foundation in recent months, has announced her resignation. She has brought passion and dedication to this hospital for a long time, but very specifically, to my knowledge, since I've worked with the foundation over the last few months, and I would highly recommend a round of applause for Kate Haygood. Madam Chair, that is my report.
Is there a link or a way to give?
Yes, there
That can
is.
be shared?
Kate, would you share how members of the board can contribute?
Sure, there is, you can go on our website.
Come over here,
Let me do it
please.
that way. Sorry, guys. Oh, stand up, I'm standing. Thanks for the question. There is, you can go on the website, which is nashgenfoundation.org. And right at the top, it'll say give. And if you click that, it'll show you all the different funds you can donate to, or you can just donate, you know, to general fund, however you want to do it. We have about 11 funds. So that includes everything from food pharmacy to women's health, employee giving campaign. There's a lot of different funds there. Medication fund. Thank you, Jeff. Okay.
Thank you.
Thank you, Kate, and thank you for the question, Dr. Scott. Appreciate it.
Thank you. The next report out is the Finance Committee. And also, thank you. Sorry, I jumped the gun here. Thank you, Mr. Lesser, for kicking this off. I mean, he raised his hand several months ago and said, I would like to see this furthered. I'd like for our community to know what we do. And for those of you who don't know him, he's not a Nashville native, but he has done tremendous things in Atlanta, and felt like he was the right person to lead this. So we have a lot of confidence in him and his abilities, as well as obviously Kathy Poole and working with Finn Partners. So thank you for chairing that as well. So Finance Committee, Dr. Enzere and Dr. Blackledge.
Hey everyone. Just going to go through a summary of the income statement and the balance sheet. We'll start with the income statement. The revenue this month for September was $170,000 less than budget. Outpatient revenue exceeded budget by $636,000 and is offset by $807,000 below budget for inpatient revenue. Admissions decreased slightly from August of 215 to 213 in September, and admissions in September were below budget by 19. Total expenses were $14.4 million, $1 million over budget. Total expenses increased from $11.5 million in August to $14.4 million in September. The primary reason for this had to do with a end-of-year adjustment accrual for expenses of $2.4 million that reversed in August. So bringing that total down artificially, if you will, and then normalizing in September. And so that's what that difference is, primarily. Some September expense trends, salaries, daily average was $175,000, which is the same for August. So that's stabilized for salary between the 2 months. Just had a day's different. One more additional day in August compared to September. Professional services, we recorded a true-up of $250,000 related to the new PSA. And pharmacy, we continue the trend of exceeding budgeted expenses by approximately $275,000. Jeff highlighted all that and the reasons that are going on with the pharmacy. I will mention on the income statement that in other revenue, we have some of those revenues that have been recorded so far with that specialty pharmacy. And the next tab related to the balance sheet, just one real call out related to cash. Cash decreased from $20.6 million in August to $13 million in September. This is as expected to fund operations and continue to pay down the backlog of accounts payable. I will mention on accounts payable, we've been ongoing to get that balance paid down, and we had a question from the Finance Committee regarding accounts over 90 days, and I mentioned $1 million. That $1 million is related to payers that are outside of we have a small group of vendors that we have payment arrangements with, and we're talking with regularly that we're paying down. That's approximately $2.1 million. And so we talk to them regularly. The $1 million is other payers for over $1 million, for over 90 days, excuse me. And then one final comment just on the income statement, just to point out, we had a negative operating margin of $729,705 for the month. This is following up on August, where we had a little over $1 million of negative margin. And we're expecting this month to be even a little bit better, less of a negative margin. So things are kind of going in the right direction there. Any questions on the financials?
One thing I noticed is that observation day, admissions may have been down, but observation days seem to be up. I know that that's not reimbursed as well, but
right.
But that was in the right direction.
Yes. The conversion factor is obviously important with those observation days. And on that note, I will point out one other stat. Emergency room visits, year to date, they're down 477. And just a little bit of the whys behind some of these numbers. And those numbers have to do with scheduling direct follow-up appointments from the ED prior to patients being discharged. This helps reduce return rates. In addition, there's increased access to behavioral health services, and this also helps to reduce return rates. So that's a little insight there. Any other questions?
Thank you. We have 4 contracts I would like to present. So 2 of them are from Radiology, 2 from Anesthesia, 3 are not in this year's budget, 1 is in the budget. The first one is the PhySynergy LLC. That's a PSA amendment for 1 year. Basically, they consolidated the anesthesia and the CRNAs so that they can flex and also cover for emergencies at night without increasing the cost. The cost is $3.7 million, but there is likelihood of a reduction based on the collections, because the collections were not factored in. The monthly amount is $375,000, and it will be reduced by the monthly collections. It's not in this year's budget. The second anesthesia contract.
Go ahead and, so before we move to the next one, does anybody have any additions for this contract? Seeing none, I will entertain a motion to approve the PhySynergy contract.
So moved.
Is there a second?
Second.
Yes, sir.
I mean, we did have anesthesia services in the budget for this year, did we not?
Yeah.
Okay.
This is in addition, kind of to, if you look at the contract summary sheet, it adds a third MD to that coverage. And then if I could get, where's Chloe? Dr. Bullock? Can you pop up if you don't mind? Just, she has the more intimate details as this is a provider services contract. And so I'd extend it to Bullock, please.
Sure. So what this does is we have had a significant market increase, and we have had 2 CRNAs that have come off of our, one resigned, one passed away. We have also we've been working with 2 anesthesia MDs for the past many years, and they are doing 2 on, 2 off. However, we are covering during the day 5 locations plus emergencies. If they are called in during the nighttime, they're I don't want to say unable, but it creates gaps the next day in coverage because they are an extension of that anesthesia team. What we have done is we have taken their coverage down, and they did give a portion of their salary back to do that for the third one, puts them at 10 days of coverage a month, and then provides a backup for MD anesthesiologists. What this also does is allow us to retain and recruit additional CRNAs, not additional, but to fill our gap. Our current CRNAs have been working about a 1.5 to a 1.7 FTE over the past year, which is why we've been able to mitigate some of this over the last year. So what we are looking to do is actually not have to pay locums costs, which is excessive, and then be able to retain and recruit what we currently have, continue in our current service. So that this is a contract that we have had. It was set to expire in October. However, just to get us to October, we extended it just a few months, ran it through the year, and then we will look at revisiting this contract at the end of the year. So this is in the budget, but a slight increase due to the current state of the market.
Thank you.
Okay. Any additional questions?
Thank you. Seeing no further discussion, I'll call for a vote. All in favor? Any opposed? Motion carries. Next contract is Stryker.
Stryker, and this has to do with a new purchase agreement for ENT equipment. The annual cost is $342,638. Basically, the equipment is consistent with what the ENT surgeons will be using. So there was no RFP process. It's not in this year's budget, and payment in full is required. So it's new because we are increasing our ENT coverage for the hospital.
Just to add for Dr. Ansray, there are a couple of service lines that utilize this equipment, ENT, OMFS, podiatry, as well as orthopedics. It's 75 pieces of equipment. Stryker is a vendor that we already use. And so this allows us to either we could pay or we could do, it's $342,000. No, I'm confusing 2 of them. And we do get a 2-year service agreement on these instruments. I believe the life expectancy of these instruments is about 7 to 10 years. The drills we have right now are end of life. We can't use them. They're beyond repair.
Thank you. Is there a motion to approve the Stryker contract?
So moved.
Is there a second? Any further discussion? All in favor? Aye. Any opposed? Motion passes. Next up is Radiology. Done.
So this is a renewal of the PSA agreement. The term of the contract is 5 years, so till 2030. It's auto renewal for a 3-year term. The annual cost is $2,350,000 with a 4% escalator in years 2 to 5. Last year, it cost $1,000,000 $877,000, but there was an increase of $472,000, which is the 4%. It's included in this year's budget, but $315,000 of that is unbudgeted for the current year. 2 quotes were received. There's approximately $800,000 that will be rebated in the form of cash collections. Dynamic would also was assigned the right to bill and collect, and then that collection will offset based on the amount of the collections.
Is this radiology services for the hospital?
Yes.
So these are the radiologists that interpret, not interventional radiology. That's a separate thing, right?
No, this is the total for radiology.
Yeah, okay. And are they on site or this is all remote?
On site 5 days a week. With call, 5 days a week.
So that is correct, on-site 5 days a week, which is a request by the facility, because we are a teaching facility. The other bid that was received was 100% remote.
Okay. Any further questions for Tim Farmer? Thanks, Tim. Okay. I will entertain a motion to approve the Radiology Dynamics contract. Is there a second? Any further discussion? All in favor? Aye. Any opposed? Motion passes. GE Healthcare.
Okay, this last one is an ultrasound echocardiogram purchase agreement. The old ultrasound echo system was Philips. It's exceeded its lifetime in terms of the service agreement and coverage. This is a 60-month lease. It would cost $395,922. 3 quotes were received. It's not included in this year's budget, but the echocardiogram machine would also be used for TEEs, which would, as we increase cardiology, it would definitely generate more revenue for the hospital as well.
I'm confused whether it's a lease or a purchase.
We're working through that, and what we have said is if it's approved, we will come back at the next meeting and let you know whether we decided to pay outright or lease it for this $8,000 per month. One of the caveats to that is our cash position, so we're just kind of looking at it. We do have a little more leeway after we receive board approval, and so we'll come back with that final adjustment.
Are these identical units, the 2 units? Like with the same probes and everything?
They are identical units.
I mean, do we need 2 TEE probes?
The request from the cardiologist was 2 TE probes in case 1 TE probe was out for repair.
Okay.
Usually to repair them probes can take up to a week, week and a half.
I think it was one thing that was mentioned in the meeting was that this had the opportunity to be a lease, essentially at an additional cost of about $85,000 over the course of that time. It was $395 purchase, and it was $8,000 a month for 60 months, correct? With the
Correct.
opportunity to buy it for $1 at the end of that?
$1 buyout.
Yes, and then also there was opportunity to, with the financing or once it was approved, there's opportunity to pay in 2027 for this device, which would give us a potential opportunity to start using it in December through 2026 to generate revenue over that 13-month time, if I'm not mistaken. Am I correct?
You're 100% correct.
Okay.
We can postpone the payments to the next fiscal year. That way we can budget for it. But we would receive the equipment in December.
So the 395,000 is not an annual cost.
It's not an annual cost, it's a one-time cost.
And so it's misstated in the, okay, thank you.
Any further questions for Mr. Farmer? Okay, seeing none, I will entertain a motion to approve the GE Healthcare contract, noting that we'll be expecting a report back next board meeting on the specific ways they plan on paying for this piece of equipment and or financing it and the terms. Do I have a motion to approve?
Motion.
Is there a second? Any further discussion? All in favor? Aye. Any opposed? Motion passes. Thank you, Dr. Enzare. Appreciate that, those details. Next up is the interim CEO's report, Dr. Elders.
Good evening, everyone, and thank you for being here. So first I want to say this team makes it real hard to give y'all any additional updates. We do want to thank our Meharry Medical College partners. We attended the Circle of Friends Gala, which you see on the front of my report. We missed Dr. Nettles as she had snuck out prior to our group picture, but we have not been invited to that event in the last 10 years. And so I just want to acknowledge that we are working on continuing that relationship and celebrating the 150th anniversary of Meharry Medical College. So I'll get right into just a few updates. First, our compensation study. The agreement that we had with the compensation study firm has been terminated for cause. If you recall, we were going to bring them to the September board meeting. It was delayed, and then they were supposed to come and report to you at this board meeting, and that was delayed as well. When we met in September, the request was to meet weekly with that team to work out the report, the detailed report, and those commitments were not made. So we did terminate that.
I'm sorry, what contract is this?
It was for the compensation study for the hospital.
Okay.
And they were due to report out in September. Then we delayed it in the September board meeting. They were supposed to report out at this board meeting, and unfortunately, we did not get a finished product that we were happy with. We, as Nashville General and the leadership team, are committed to just a well-researched report for this type of work, and we want to make sure employees feel valued and fairly compensated, and that just did not happen with this company, and the deadlines were just not met. With that, I do want to talk a little bit about our service awards. So in recognition of years of service, we've typically always, every year, provided longevity pay, which is a supplement pay for employees with 2 or more years of experience. We will be doing that this year as we strongly feel like we need to do that, as we are currently on pause for the across-the-board increases. Pending 2 things. I'll say organizational growth as well as completion of the comprehensive compensation study, which, as I noted, has been delayed. And so we have about 391 full-time employees that will receive this on the first paycheck of December. So we just wanted to let the board know that. We have also working on our human resource transformation sprint. We've engaged Deloitte for consulting services with a contract with Metro Procurement. And our goals are to address the key process gaps and transparency concerns and challenges that we have heard about over the last few months. We aim to align our HR practices with industry standards, and we're working to rebuild the workforce's trust in our human resource processes. Our kickoff meeting was this week, and this project will last for about 4 weeks with a completed date of December the 1st. It was a additional contract that did not require board approval, and it went through Metro Procurement. For our Crossland Audit, that kickoff was August the 29th. They started September the 8th. They had 2 auditors on site Tuesdays and Thursdays through the end of September. We had reported out earlier that they would end in mid-October, but they've completed that. There are a couple of items that they're still in conversation with Dr. Blackledge on, and as we get an update on the audit, we will provide that moving forward. As I mentioned about our Meharry partnership, I feel like it's stronger than it's been. since I've attended or been an employee here, we're working with them on a new marketing campaign to launch our partnership and showcase our partnership and relationship to the community while also promoting access to care. We're working with them on a clinical research center as well as looking at our parking garage and facility needs. I mentioned previously our partnerships with multiple metro departments, which we have been able to I'll say continue, and I think we're very proud of that. The Metro Public Health Department, the Metro Office of Family Safety. This winter, we'll be partnering with the Metro Office of Homeless Services. Our team will partner with them for their cold winter weather shelter on the days that it's operating, which is when it's consecutive. It's a 32 degrees consecutive for 3 hours. So our emergency department leadership is working on that initiative on behalf of Nashville General. We also have joined the Tennessee Diaper program, and so that will be a big addition in working to drive our women's health volume. Patients I'm sorry, I got stuck. Our women's health team will provide diapers to mothers, the patients that are delivering and have gone home with their newborns, and it'll be integrated into the pharmacy's Med to Beds program. Christy Lewis covered our Tennessee Department of Health, and I would just say for us at Nashville General, we just need board support for continued improvements to the existing infrastructure, as well as securing a future for Nashville General Hospital. As you see in the world, we will be needed even more in the future, and that is my report.
Thank you very much. And it was a nice celebration, and it was enjoyable to spend some time with Meharry and Dr. Hildreth. I mean, he came up and was just thrilled that we were there and said some very, very kind words. In his first, the 2 sentences were about the PSA signing and obviously his relationship he's built with Dr. Elders. So just wanted to brag on them a little. No one needs to hear anything I have to say at this point, so let's just talk about our next meeting. Our next meeting will be Thursday, November the 20th, so that's a little off schedule. Yes, sir, go ahead.
Madam Chair, I have a question about the compensation study.
Yes,
No,
sir.
yes, sir.
Have you checked in with Metro Procurement to see if they have a group or vendor?
We will be. The original ask, and is the process we followed, was to get recommendations from our legal representation, Spencer Fain. There were 5 companies that were provided, and one of the companies was selected out of that 5. And so right now we'll be working with our board chair, and Metro Procurement is a good option to look at who to do that with.
And I'm just wondering if Metro might be able to pay for it.
No, no, I don't think they will, but it's okay. Like we're even I'll say we talked about the Deloitte contract. We went through Metro Procurement, but we are still responsible for the payment of our contracts. This is something that we need to do for our hospital, for our employees. I believe there's been some talk about inconsistent pay practices in the past. We want to dispel those, and our board chair has requested this report, and so we want to make sure we have a good, excellent product for our team. Thank you.
Thank you. It's really important. I've seen it done on other boards, and I think it's something that will provide validation. But also, if there are any issues, then we know about them, and then we're addressing them proactively. We have amazing people that work here, and they need to be paid adequately and fairly, and I think this will help showcase that, and people will be proud to know that they're in alignment. November the 20th will be our next board meeting. Again, that is the week prior to our normal schedule, so I don't know many of you that want to be here on Thanksgiving. So that is the next date for our meeting. December is canceled for the holidays, so I know many of you are sad about that, but we will reconvene with you on January the 29th, and so that will put us back on schedule. Again, please pay attention to 2 things. One, Ms. Lester's emails to you about the committee meetings. Make sure you RSVP appropriately and respond to her invites. And two, if she asks you specifically to be helpful to, be a board member and presence for one of these wonderful things that they're hosting here at the hospital to support our employees and the partnerships, please make sure that you're RSVPing to those so we have some good board representation. That being said, again, thank you for our 2-year experience with ethics, and we will go ahead and entertain a motion to adjourn. Yes, sir.
Janet, can you send out an announcement about the advancement committee meetings in case others want to join?
Entertain a motion to adjourn.
So moved.
Second? Not everybody's talk at one time. All in favor? Motion carries.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information on this and other programs, visit nashville.gov. This has